we are live. It is 1 o'clock. Thank you very much for being here. Welcome to the Lessons Learned from the Youth Opioid Response Grant session with NAMI San Diego. My name is Jim Crittenden. I'm a program specialist with the San Diego County Office of Education. I am just here to introduce our speaker and to let you know that if you have questions, please put them in the chat. If you have questions of our speaker, we'll be monitoring that, and we'll have plenty of plenty of time at the end to do a Q&A with those questions. If you have other questions about county and live well or the San Diego County Office of Education, you can also put those in the chat, and we'll do our best to get those answered. With that, let me introduce Karen Lenyon. She's a program manager with NAMI San Diego and will be your speaker for the day. Karen, take it away.
Great. Well, thank you so much, Jim. And it's great I would like to say it's great to see all of you here today.
Right.
However, I can't see anything other than my presentation on the screen. So as we're all getting used to this COVID environment, we've had to adjust, right? So as Jim said, my name's Karen Lenyon, and I have several different titles after it actually at NAMI. And that's kind of what we do. We're sort of like Swiss Army knives in that we have multifunctions and many purposes. So I think in the last year and a half, 2 years that I've worked there, I've had probably 5 or 6 titles in different functions, everything from managing this new program to collecting data. I also help co-facilitate some of our support groups and our family-to-family classes. So we all do a lot of different things. And Suzette Southfox is our Director of Education. She was supposed to be here with me today. However, she lives in an area where SDG&E has turned off all the power. So she apologizes profusely via text that she cannot be here today with you. But she was definitely my partner in this project that we had last year through the Youth Opioid Response Grant. So we'll make sure that we give her a shout out about all the great work that we did on this together. So here's what happened with this grant. About a year and a half ago, the MAT expansion, MAT is the Medication Assisted Treatment Expansion Project 2.0, decided to put out an RFP to look at both planning grants and implementation grants. So NAMI San Diego was awarded one of the planning grants, and the purpose was to look at ways to make medication-assisted treatment more accessible to youth that are in the TAY population, so transitional age youth, and actually going down to age 12. So that was the purpose of the grant. So here's what we did. We had some goals. So we convened these person-centered community-generated events. We picked 2 regions, the North Central region and the East region. And the reason for that at the time was because those were the 2 regions, according to the data that we had available to us from 2018, that had the highest opioid overdose rates, according to the Prescription Drug Abuse Task Force report card. So we partnered with some organizations in those areas and did these community-generated planning events, which we called community brainstorming sessions. And we used the community wisdom of youth and families and those who were in treatment, those who were giving treatment. So we had a large population, variety of different consumers who participated in these events. And so we went to the prevention community, we looked at intervention, we looked at medication-assisted treatment and overdose reversal medications, and then we devised pathways to implement a strategic plan. So that's pretty much what I'm going to cover today. So here is some explanation of what actually took place. And remember, this is pre-COVID when we got started. So I don't know if you remember these days, they seem like a long time ago when we used to be able to gather in person. I'm a little actually, reminiscent and having some emotion here about this picture because we all miss gathering together, right? So these were fantastic events. We had people that came. This one, we had probably about 70 people attend. It was at the Santee Community Collaborative. and our partners there. We were so grateful that they hosted our first one. This was in August of 2019. We used what we call the ICA model for community collaboration and intervention. And so folks saw a presentation kind of similar to what you're going to see today, and then they were able to get up and collaborate and put together their ideas via these little slips of paper. And then we coordinated those into different categories. So here's a little bit more of a close-up picture. This is Suzette over here leading the charge. I'm over here kind of organizing, and these are community members and also folks that are involved with intervention in the community as well. And so here is Suzette actually at one of the high schools. So as I mentioned, we looked at different populations. So we had college students, we had high school students. So this was over at Mission Bay High School in the North Central region, where we worked with some students and parents there and did kind of the same process. We also did a social media campaign. So this was our #YourCalifornia social media campaign that we ran prior to each event. This particular one, I just love this graphic here. I wish I could say that I was the one that created it. I was not. But imitation is the highest form of flattery. So I used it, got permission to do that, and it was really a big hit. We had thousands of hits on this. And so these social media campaigns actually ran in March and April after COVID hit, and we were doing everything remotely. We also had some print media. So our friends over at the Institute for Public Strategies did a couple of pieces for us in the East County when we did another presentation out there. And so now I want to talk to you a little bit about the reason why we need to pay attention to this. And this has to do with the data, right? So remember I mentioned we were using the Prescription Drug Abuse Task Force from the previous year when we applied for the grant. So this is actually the most recent task force report card. And as you can see, the numbers are seriously going up. So we've had a huge increase in overdoses, particularly since COVID has hit. And I'm going to talk a little bit about that a little later. But you can see some of the numbers here from prescription drug unintentional deaths, as well as fentanyl caused overdose deaths. And the data, unfortunately, always lags a little behind. So the situation is probably a little worse than what we're seeing here. As a matter of fact, we know that this 151 number will in fact go up because we have another 57 fentanyl overdose cases that are still under investigation. And at the time of the issuance of the report card in September of 2020, the fentanyl overdose deaths were at 259, and the year is not even over. So I'm sure if you've watched the news at all or read any newspapers recently, you've heard about this and what a problem this is in our county and also in the country. So there's a lot of numbers on this page. Just a couple others that I wanted to point out to you where the news is a little bit more positive, and that is in terms of the number of pills that are being dispensed per resident. So we've really done a great job with working with physicians and prescribing doctors so that we don't have as many opioid products being prescribed, right? So this number has come down to 22.8. That's 22.8 pills prescribed to each person in San Diego County. So we have about 3.5 million in population in San Diego County. So multiply that by 22.8, and that's how many prescribed pills there are, or there were in our county in 2019, which actually is better than it was in 2015 at 39. So, and these are just some more numbers from the data on the report card, and this indicates what's going on with the heroin market. So we can see that the heroin overdoses were another 124. So the total overdose deaths in our county in 2019 were 532, which is way too high. Way too high. And so, and many of those were young people as well. So the purpose of the grant was to primarily focus on young people so that those rates could be reduced. We can start working on treatment for misuse conditions and and hopefully reduce use and reduce overdose deaths as those individuals mature and grow. So that was the purpose of doing this planning grant. Now, you can also see here the fentanyl epidemic on a graph. It's a little bit differently displayed, but we didn't know what fentanyl was back in 2004. And now all of a sudden, come 2014, we have this huge spike in the increase of fentanyl overdose deaths. Fentanyl is a synthetic opioid, for those of you on the call who may not realize that. So, my understanding of substance misuse and opioid misuse, and you'll always hear me use words like misuse rather than addiction and addict, and because at NAMI we're very concerned about stigma and using the correct terminology. So with substance misuse, I used to say that my understanding was very linear. So I thought, mistakenly, that if someone had a misuse condition, they could go to, there were like maybe two options. They could go to treatment and develop some skill sets where they would not be misusing the substance, and they would be well and move on with their life. Or they would suffer an overdose and have some serious consequences from that. And that was kind of how I looked at it. And I think that's how a lot of people used to look at it until we've had a little bit more education and gotten a little bit woke about this issue. So now we talk about the ripple effect, because there are many, many more things that can happen when an individual has a substance misuse condition, an opioid misuse condition. So I have a picture here of something indicating the data around neonatal abstinence syndrome, which occurs when a mother gives birth to a baby while she is misusing heroin or some other opioid. And there are a whole host of other issues that can happen with substance misuse. Everything from staph infections to heart disease to endocarditis to open heart surgery with valve replacements. The list goes on and on. It's really a very dramatic and serious health condition, and that's how we need to look at it. So some other things that happen with this ripple effect, and I want to talk, since I know that this is the youth platform that I'm working with here, and we may have folks on the call here who are in education, and that is the children who are affected by the opioid epidemic. So this paper I found a few months ago, it's a little bit outdated. As I mentioned before, the data runs a little behind, but at the time of this writing, we know that 2.2 million children were affected in 2017 by the opioid epidemic. And this paper just shows a little bit how that breaks down, right? So we have children who are living with parents that have an opioid misuse condition, children who have a parent who has died, passed away from an opioid overdose, children whose parent may be in prison as a result of their drug use, and then children who have been removed from the home and are in foster care. And then the last category is children themselves who have developed an overdose, or I'm sorry, an opioid misuse condition. And so that's 2.2 million children. And if we take that out and look at these numbers calculated out to 2030, the scenario can be looked at in a few different ways, but none of it is really that positive. I mean, even at the best and most optimistic scenario, we're looking at 2.2 million children right now affected. This number could feasibly grow to 1.2 million. An additional 1.2 million, so a total of 3.4. That's the optimistic scenario. There's, a base scenario, which is if we don't do anything and keep going along the path we're at. And then there's a pessimistic scenario, which could actually bring us up to almost 5.5 million children affected. So it's not just an individual or an individual family's issue. It's actually a societal issue. And if the numbers for the individuals and the human costs don't get you, then if you look at the societal costs, these are other staggering numbers, because we're looking at an estimated lifetime societal cost of $180 billion. And that's billion with a B. So, and these charts here break down what exactly that each category comes from. So whether it's increased healthcare, treatment, children who are in welfare programs because they are in foster care, special education. It really expands and goes on and on. And then there's the long-term societal costs because these children are developing many ACEs, adverse childhood experiences. So their scores are very high. So they're very much at risk for all of these other items that happen as a result of their high ACEs. So they might be more likely to be arrested, be depressed, smoke, use substances themselves, and it just is a very serious situation for our society and as a whole. And so when we look at the opioid epidemic and we compare it to other childhood health conditions, this chart I found very interesting, because we hear a lot about childhood diabetes and even children with autism, and yet those numbers are actually lower than children affected by the opioid epidemic. So, and also keep in mind still that these numbers are a few years old, so they are most likely higher right now. So we have 2.2 million children versus 0.19 that are affected with diabetes, 1.8 children with autism, and then 6 million children with asthma. So just to give you some perspective on how that compares to other childhood illnesses. So now I want to talk a little bit about COVID-19 and how that has affected the pandemic, overlapped with this epidemic that we already had, and just the seriousness of some of the things that we're seeing. So we know that folks who suffer from opioid misuse conditions are more likely to be experiencing homelessness. We know that they may also have comorbidities. These items are all making them more vulnerable to COVID-19. We know that their respiratory and pulmonary health may be severely affected because of their opioid misuse, and thereby increasing the severity of COVID-19 should they contract it. We know that many individuals may be incarcerated because of their involvement with the criminal justice system as a result of their opioid misuse. We know that there was decreased access to the recovery community, and I have some really interesting charts about that because what happened when COVID hit is we all went to telehealth care, right? And so folks were not able to access their recovery communities. We couldn't meet together. They couldn't go to their meetings, meet with their support groups. And so this really seriously affected and intensified the opioid misuse situation. And then the intensified marginalization with an overburdened healthcare system. So we already had an overburdened healthcare system. COVID, really affected that. And so now this whole group of individuals was very marginalized because of that. And then finally, the stigma, the racism, the fear of the healthcare system. Quite honestly, individuals with opioid misuse conditions have not been welcomed and treated well in the healthcare system previously. And so there is a fear of the healthcare system because it in large part has failed them. So, and then some other things that happened. So what happened when the stay-at-home order went out was we were all told to isolate and to quarantine, right? So we were told to stay at home and not socialize, be socially distant. Well, what is it that we tell folks who have an opioid misuse condition and are using IV drugs? We say, don't use alone. So this, of course, immediately forced an entire population to use alone. The drug supply chain was disrupted. The border was closed. Drugs weren't getting across, which explains how we had such a surge in fentanyl overdoses over the summer. The syringe supply was disrupted, and there's other issues dealing with the syringe supply disruption. So we have other diseases, hepatitis, HIV, the overdose with physical and social distancing, which I already mentioned. And then they're at greater risk because of that. And it's vital really to remain engaged and consistently accessing your necessary medications. So if they were on medication-assisted treatment, that may have been interrupted, which again could have forced higher usage. And this was not only a San Diego problem. These numbers, this article was written in the Washington Post a few months ago, just about how the entire country is seeing this increase in overdoses with opioids. And so it was estimated that, and this was back in May that this data was collected, but overdoses increased, was up to 42% per month during the pandemic, during those really essential months, March through August. And now, of course, we're seeing a surge again. So here's, and you can see this is data from San Diego County. So you can really see the impact of what I just explained. So we have a month by month calculation of the overdoses that happened in our county. We get to March, which is when the shelter in place order came, and you can just see that the numbers just skyrocketed, with August being an astronomical number. There actually were more overdose deaths in August of this year than there were the entire year in 2018. So just really significant numbers here. And then at the same time, we can see the access to care, right? So, sorry, I keep doing that. Oh my gosh, I'm having mouse issues. So prior to the stay-at-home order, we have mostly in-person services, which is represented by the blue here. And then March hits, we have almost, I mean, really this drops off severely, significantly, right? And then we have phone and telehealth calls here. But still, for the baseline, which is right up here, we see that many individuals, the access to care and the use of outpatient services was really dramatically increased as the pandemic went on. So, and I haven't looked at, because I'm basically presenting blind, I can't really see who is here in our audience, but many of you may have been. I know we're all very interested. Those of us that are in the prevention and treatment world are really interested. And I listened earlier to some of the other presentations because we're kind of obsessed with this topic, right? So some of you may have been at the conference last year that happened in San Diego, which was a fantastic conference. Again, that was pre-COVID, so we were all together personally. And the Surgeon General was there, Jerome Adams. At that time, he was the top doc. Now I'm going to say probably Anthony Fauci is the top doc. But anyway, back then it was Jerome Adams, and his presentation was incredible. And if you were there, you remember what he said about stigma. And he said that people often ask him what the greatest killer is as far as health-related items go. And he said people will say, well, is it sugar? Is it smoking? Is it drugs? And he said, actually, the biggest killer in society is stigma. And the reason is because stigma keeps people from getting help. And sometimes it keeps them from even admitting that they need help. And as I mentioned at NAMI, we are very big on stigma busting and the impact of stigma, because not only on substance misuse, but also mental health and co-occurring conditions where we have the two together. And so I love this sign because it really brings home the point that this is a medical condition. Addiction, substance misuse are medical conditions. And just, we should be treating them. We should be treating the patients just as if they had any other medical condition, such as cancer or diabetes. So, and the prevalence of stress in this COVID environment has been unbelievable. We've seen a 60% increase in our calls on the helpline at NAMI. And I know that this is happening across all platforms here in San Diego for folks reaching out for help. We know that teens are reporting and experiencing much higher rates of stress right now. On a 10-point scale, they're at 5.8 versus where they used to be at 3.9. We know that 31% of teens are feeling overwhelmed, and that 30% report feeling depressed or sad as a result of the stress that they're under. And then you can read through the rest of this slide on your own. I hate it when I go to presentations and people read the slides for me. I'm basically just filling in what is on the slide. The point here is that the stress of COVID-19 has really increased the likelihood of substance misuse. And I have a new term now. Instead of saying self-medicating, because I'm always looking for better ways to say things, we call it relief seeking. a little sticky up on my desk and on my other computer, just so that I remember to use that term. So relief seeking as opposed to self-medication, but folks are seeking relief from some of the things that are going on in their lives. So this is actually the result of the Pulse survey. I don't know if any of you have heard of this, but the CDC has been doing this survey since COVID hit, and they have a really interesting website. I've put it down here at the bottom. At the end of my slides, I have all of the resources. I'll be posting these up on our site, so you can download them if you want with all the resources. But so you can go in to the Pulse survey and pick a point in time. So they do this every 2 weeks. So it's very interesting because the last time I pulled this was for a presentation a few weeks ago. And I pulled a point in time that was at the beginning of October, and California was actually way up at the top here. I think we were like the second state, we had the second highest anxiety and depressive disorder. You can also sort by anxiety and or depressive disorder, or both together. So the results are really interesting. You can play around with it. It's live data. So, and in case you can't tell, I love numbers. I'm a little bit of a data geek. But so when I pulled this the other day, I thought, well, why is the District of Columbia up here? I've never even seen them on this chart, because I've been watching this chart for a few months now. And then I looked over at the date. And so I'll let you guys decide why DC is up there at the top, because look at the date here this week. Something happened here at the beginning of November in DC. So that explains why the stress level in DC was higher than anywhere else in the country. A little thing called the election. So co-occurring conditions prevalence, we almost automatically assume that someone with an opioid misuse condition has a co-occurring condition as well. And this is also some national data, but just look at these numbers here for any mental illness. So there's 64.3% show that those with an opioid misuse condition also have any type of mental illness. And then there's other data here for alcohol, cannabis misuse, tranquilizers, etc. Again, not a linear type of issue, right? And so I love the Venn diagrams because it really can visually give you the information in one fell swoop. So we know that 39% of those with a substance misuse condition also have had a mental health condition, right? So that's this number right in here. But for adolescents, that number is way higher. It's about 90%. So we know that 90% of adolescents have both a substance misuse condition as well as the mental health condition attached with that. So addiction is a chronic relapsing brain disorder with the potential for recurrence and recovery. This is one of my favorite definitions for what substance misuse is. And when you compare it, I found this data, this chart a while back. I think Dr. Lev used this in one of her presentations, and I was really struck by it because we always talk about relapse, right? And we only talk about relapse in terms of substance abuse. But if you look at other chronic illnesses, their relapse rates are similar or even higher than those for substance misuse. So, asthma, higher, hypertension, who doesn't forget to take their blood pressure medication, right? So that's considered relapse. And yet we don't look at this kind of relapse in so much negativity as we do with substance misuse. So just something else to keep in mind in terms of the stigma that folks who are suffering with this health condition see on a daily basis. So why do people seek treatment? So they might want to detox and break the cycle of the illness. They might want to lower their individual tolerance. So maybe not necessarily stop using, but lower their tolerance. They might want to relieve external pressure from family, because someone's getting after them, work, they're having issues, or the justice system is always a huge incentive, right? They might have internalized ambivalence about seeking treatment. They have internalized motivation. And then there are some reasons why they don't seek treatment, right? So that maybe they're not ready to stop using. Maybe they have fear of the consequences if they stop using. maybe they don't have healthcare coverage and they can't pay. So it's estimated that over 30% have an inability to pay, even though we have, many free programs. Sometimes they're very difficult to get into. Sometimes folks don't know about them. And if you've ever had a loved one and tried to find treatment for them, you know what I'm talking about. Fear of negative consequences, either on their job or with their friends, families' opinion. And so exactly how many people are in treatment in the county programs, and keep in mind that these numbers are county data treatment. So we don't really have numbers from private treatment. So we know that the majority of those that seek treatment, this red line across the top here, is that they're there because of their meth misuse. And then really close to that is heroin misuse. And then the numbers go down from there. So we have alcohol, marijuana, cocaine, and then pills, prescription pills. And then if you look at the age range, because that's really what we are talking about, is our young folks, right? In that age range, even less than 17, up through age 25. So really the majority of the folks seeking treatment are older. They're above the 25 level. So the purpose of this grant, the goal of this grant, was to find ways to get folks into treatment sooner, because the sooner they get into treatment, the better the outcomes, right? So a word about harm reduction, and I don't know if some of you were in the presentation earlier today from the California Bridge program, which is an excellent program. And they talked a little bit about harm reduction, and some of my information is a little bit similar. So I apologize for the replication here and duplication. But harm reduction has become almost like a political movement now, and it's focused on shifting power and resources to people most vulnerable to the structural violence of not using harm reduction. It incorporates a spectrum of strategies, not just one thing, and it talks about managed use and can actually even include abstinence, but doesn't really focus on sheer abstinence. It meets people where they are. Remember when I said folks they may just want to reduce their use and not stop. So that's what harm reduction is. So if we can reduce use and bring some of those tendencies and the likelihood of an overdose happening under control, then we have a better chance at treatment. And it doesn't minimize or ignore the harms associated with either licit or illicit drug use. It just applies evidence-based interventions that can help reduce the consequences of some of the behaviors, right? And then it moves past judgment, which is really important. And it works to elicit any kind of positive change based on the individual's needs, their circumstances, their readiness to change, and even their ability in believing that they can change. So, and here's what it's not. It doesn't mean that anything goes. There's really a lot of myths around harm reduction. It doesn't enable drug use or high-risk behaviors. And it doesn't mean that you're not endorsing or encouraging drug use. And harm reduction does not exclude or dismiss that abstinence-based treatment models are a viable option. It just gives other options. And so these are some of the harm reduction services. And you've probably heard a lot about, medication-assisted treatment and Naloxone. We're a long ways away from supervised consumption services or drop-in centers. We have a ways to go with housing and pharmacy access. But so focusing on the top level here, we do have some incredible organizations in our city that are sponsoring syringe disposal and syringe access programs and giving education about safer drug use. So those are all harm reduction measures. And so we also have some challenging myths about medication-assisted treatment. So one of the myths is that it just trades one addiction for another, which the fact is that it does not. The research indicates that a combination of MAT and behavioral therapies are very successful in treating substance misuse conditions. There's another myth that says that MAT is only short-term. And I used to think that also for my loved one, that maybe they would not be on MAT for a duration of time and could possibly titrate off. And this is also a myth, right? Because research shows that patients on medication-assisted treatment for 1 or 2 years have greater rates of long-term success rather than titrating off after just a few months. And that some folks feel that maybe their condition isn't severe enough to require MAT. That's also a myth, because MAT utilizes a multitude of different types of medications, which I'll show you in just a sec. And that the other myth is that MAT increases the risk of overdose in patients, and that could not be farther from the truth. And the reason is because of this issue about tolerance, right? So following detox, individuals with an opioid misuse condition are very vulnerable and susceptible to overdoses. So the higher tolerance to the respiratory depression, so if they continue and keep on a medication-assisted treatment program, the likelihood of overdosing is reduced. And then finally, providing MAT will only disrupt and hinder a patient's recovery. That's also a myth, because MAT has shown, and we have lots of research around this, that patients do recover and they stay in recovery long-term when they're given medication-assisted treatment. There isn't any proof that MAT is better than abstinence. That's also not true. Again, we have lots of research about that. And then these are some of the medications that are used in addiction treatment. There's been a big push for buprenorphine, also known as Suboxone. It goes by a lot of different brand names. Basically, it's a mixture of buprenorphine and naloxone, and it's termed a partial agonist. It's about 60 to 90% effective. Not everyone does well on buprenorphine, surprisingly. Actually, methadone has been the tried and true medication-assisted treatment for many years. And it still is. I mean, it still is very effective medication, especially for long-term users. So the patients just really have to figure out which medication is better for them. Just like medications that we use for cancer, that we use for diabetes, some medications work better for some patients than others do. And then there's naloxone, which is the overdose reversal drug, and is really a godsend. Honestly, this has saved hundreds of thousands of lives. And just to show you, in our city, these are emergency service saves. And as you can see, it has really increased over the last few years since we've had this issue with fentanyl on our streets. And then also the saves from the sheriff's department, because they've started carrying naloxone back in 2014. And you can see the huge increase in 2019, and it's headed to be even higher than that for 2020. We don't have all the data yet. So very effective medication, and it does save lives. And folks recover. They get into treatment after they have a situation where they've had to have naloxone save them, and then they are referred for treatment. And many people do recover and enter a medication-assisted protocol. So MAT prescribing data is on the increase in San Diego, which is great. And that's, if I can say anything positive about COVID, this might be it. And that is that the DEA actually relaxed some of their guidelines around some of these treatments. So folks were able to have take-home packs, which was pretty much unheard of with methadone prior to COVID. I mean, you had to be on a methadone protocol for a long time before a take-home pack happened. So that's happening more regularly now. So that's where you get to take home the medication. I mean, the name is kind of obvious, but with methadone, basically individuals prior to this had to go every day for treatment and for dosing. And so at the very beginning, they still do that, but the take-home packs have become more regular and more common, which is great. And then the same thing with buprenorphine. Used to be that the take-home packs were like for a week, and now they're giving monthly take-home packs. And it really has increased the effectiveness as well. So we're hoping one of the strategies would be that the DEA would keep some of these emergency measures in place even after COVID is no longer a threat for us, because it's been effective to have that available. So we know that youth are not receiving medication-assisted treatment at the rate that they could be or should be. We know that only 1 in 4 youth diagnosed with an opioid misuse condition receives any kind of medication-assisted treatment. And then only 1 in 3 received medication-assisted treatment in the last 12 months. And then youth of color, the numbers are even more dismal. So Black youth were only 42% less received medication-assisted treatment compared to white youth, and Hispanic youth 17% less. So those numbers, we need to increase those numbers. We need to do something about that. So that was the purpose of all of our surveys and everything that we did with this grant. So this just shows a little bit about the survey questions at the end of our presentations that we did. Most folks really understood a lot about barriers to treatment and the ripple effect, but the numbers that I found really kind of interesting was the awareness of MAT treatment and MAT in their region. So I expected these numbers to be a little bit higher, especially with some of the folks that we were working with, but they weren't. And this was even after the presentation. So that leads me to believe that perhaps we need to do a better job about really getting the word out about how to access those treatments. And then these were also the results of some of the things that were up, those sticky notes that you saw at the beginning of the presentation. So this is what they said. We asked them about youth access points, what helps and what hurts. And so, you know, the youth had a lot to say, and the folks that were in recovery from substance misuse conditions had some really great things to say, you know, things like, you know, forced abstinence programs, counselors who weren't supporting medication-assisted treatment. I mean, these were all listed as things that would hurt. And then over here were things that would help. And so we had the 4 categories. We had youth access points, preventing delays in treatment, staying stopped. And so this is a term, I really like this term. So so some of the folks that I know that are in recovery are saying, they tell me, you know, sometimes it's easier to stop than to stay stopped. And so these are some of the things that the attendees said would help in staying stopped. Jobs, you know, part-time jobs, huge part of really staying stopped. Long-term aftercare, you know, so the 30-day programs, the 60-day programs, we need to increase that. Family support, you know, waiting for someone to hit rock bottom and having them learn their lessons. These are languages that we really should not be using, because that relationship with family is really what gets people through. So our strategies, and this is the part that you've been waiting for, right? And you've all been really patient. And I know I'm talking a mile a minute because I want to get to your questions. So some of the things we could do, here's the immediate actions. These are things that are pretty easy. And, you know, I did them by levels right here. So we've got like 1 weight here because this is level 1, relatively easy things. Some of these are already actually happening. You know, support and expanding existing prevention efforts. We have some great prevention providers in the community, continuing to support and join in with them. So, and then now this level is getting a little bit harder, right? So we've got level 2 now, or I'm sorry, this is level 3. Improve efforts to expand early intervention to treatment. So we need to have access and entry points at low barrier treatment levels, okay? So these are some of the things that we talked about, the emergency department visits, and we're already doing that with the Bridge program, and that actually has just been expanded because the Bridge program is funding most of the hospitals in San Diego County, which is fantastic. And continuing to advocate for minimal wait times. If you've ever tried to get someone into treatment, you know, sometimes the wait times are pretty long. And so when someone's ready to go to treatment, they need to get there quickly before they change their mind or they become discouraged. And then encourage providers to use the telehealth per COVID-19 revamped guidelines. And I talked about this a little bit earlier when I was talking about the DEA requirements, right? And we've got some research right now about telehealth, and it's surprising because I really didn't think that telehealth could be as effective. And many of the therapists that are in my life kind of were thinking the same thing, but actually the data is showing that telehealth is very effective. And so some of the other things are to improve support for pregnant and postpartum women. And that neonatal abstinence syndrome that I was talking about earlier, this is something that we're working on to really help pregnant mothers to deal with their misuse situations while they're still pregnant, and be able to keep their babies. And then partnering with organizations that foster cultural diversity and inclusion, just because we see that the youth of color are really not receiving treatment at the same rate that white youth are. And so that's really important in our climate for today. To improve recovery support services, right? So support medication-assisted engagement, offer NAMI signature mental health education. I have to give a plug for that. Our education programs are incredible. We have peer and family supports. We have the family-to-family class. Advocate for funding for medically managed withdrawal services. We don't really have very many medically managed withdrawal services in San Diego County. Sustain advocacy around discontinuing zero tolerance practices and treatment, because that does not work for everyone. Partnering with local agencies to address the barriers to housing and employment. This is huge, because if folks don't have housing and they don't have any way to support themselves, recovery is going to be very difficult. So that's our level 3. Then we have our level 4. We're getting a little bit harder here. So increasing addiction medicine specialty services in hospitals and areas where insufficient. So what is this? So we have addiction services in the ER, but we also need them in long-term hospitalizations. So my loved one was in the hospital for 3 months with a medical condition as a result of an opioid substance misuse. And there were no services for his substance misuse condition. There were great services for his physical ailment, which happened to be his heart, but there were no services to address substance misuse. So we need to consider that, to bring those services not only in the ER, but also for extended stay patients. And then there's several other items on this list, but we're running out of time, so I'm going through this really quickly. And then this is my wish list right down here. So legislate permanent support for countywide funding of syringe exchange programs. We have Family Health Services, which funds a syringe exchange program, and I believe there's another one actually that has also started as well, but they're limited. They're not in every place in the county. They're downtown. Folks in North County can't get to them, so we need county funding for that. Permit and fund additional OTPs. We have 10 opioid treatment programs. That's where folks can obtain methadone. It's not enough in the county. We need more. And consider a mobile MAT unit. So, especially for methadone, folks have to go every day, and to get to a methadone clinic and an OTP every day is a barrier. So consider a mobile MAT unit. So like I said, these are on my wish list. We get a double weight over there for level of difficulty. And then the last thing I want to talk about is, because that youth opioid response grant sunsetted in September of this year. But lo and behold, we now have a new project. I always have to have a new project that I'm working on. And so this one, and because this is our schools segment here that I'm addressing, that's why I kind of wanted to tell you about this. So Elevate Youth California, we're going to be addressing co-occurring conditions in targeted populations. And we want to bring this to the schools as well as to our TAY population. So we have some homeless shelters that we're working with that cater to transitional age youth. But we have a fantastic suicide prevention peer instructive program that we're offering. We also have a 6-part situational self-leadership training that we're also offering through Credible Messengers, which are our peer supports, so that the youth are, talking to someone that looks and talks like they do. And then we will continue to offer our family and loved ones natural supports through our signature NAMI programs. So that's our new project, and hopefully maybe next year at the Advance I can give a presentation about how that's going. If you have any questions or you want to contact me, there's my contact information. And so now let's see, Jim, how are we doing on the questions and interactions here? Because I've been
so we have a couple of questions, mostly about the resources. Will you be able to share your PowerPoint
Absolutely.
If they contact you, are you willing to share your PowerPoint? And also there was a question about the sources, the links and source, or can you provide links to the sources that you used for your data? So
Yes.
those are the two big
Yeah.
questions.
Oh, great. Okay, good questions. And yes, so here are all the references and resources. I'm going to post these up on the website. So just give me a minute for after this ends and I'll have this up on the website. You can download it and use it as needed. And all of the links are at the end here at the very back. So you can pull up all that great data, which was so exciting. Any other questions?
Anna had a question about, is there opioid prevention curriculum available for middle school and high school? I typed back to her quickly that the DEA and Operation Prevention San Diego, I will make sure I get her that link to that curriculum, but do you know of anything else other than what the DEA is doing?
Great. Yeah. Yeah. And that is great curriculum, Anna, but also the prevention providers. I don't know what part of town you're in, but our regional prevention providers, so say San Diego, Institute for Public Strategies, they all have curriculum and do presentations on opioid prevention as well. Anything else?
Those are all the questions for now.
This is a miracle. I actually have never, I've never gotten to the end of the presentation with time left to spare. So I feel like maybe we should go back through and go over some of the things that I glossed over so quickly, but no, I'm just kidding. So that was great. Well, you've been a great audience, even though I can't see you at all, but
I know.
I really appreciate you all being here. I'm looking at the attendee list. I see some of my friends here from say San Diego and from NAMI San Diego. So great for the support. And so it's really, really wonderful to see all of you on the participant list. I miss seeing all of your faces. So hopefully we will be doing that again really soon as that vaccine comes out. So then we can all meet together again sometime next year. So I thank you all for your attention and for your participation. And maybe you have a little time, a little break here in between where you can go grab a glass of water or a cup of tea and before you go to the next session. And have a wonderful rest of the holiday season. I wish you all the best. Stay safe and stay positive and test negative.
Thank you, Karen.
All right. Thank you, Jim.